oncology at the University of Zimbabwe and a radiation oncology clinical fellowship with the University of Toronto. So, Dr. Mushonga's research interests and clinical practice have allowed her to have extensive experience with thoracic radiotherapy, and that is why she's going to be speaking to us today about thoracic radiation, but trying to make sure that it is, stratified to resource levels within Africa. So Dr. Mushonga is a member of oncology organizations and recipient of prestigious awards, including the 2019-2020 African ACLI, Africa Cancer Leader Institute Fellow, Africa Clinical Trials Consortium NCI Award, Global Oncology Leadership Development Gold Award, Princess Margaret Hospital Award, University of Toronto Fellowship Award, Radiation Oncology Program 2020 to 2022. So multiple award winner, ASCO Young Investigator Award in 2022, recipient for the Breast Cancer Research Fund, and Global Oncology Program Fellow 2022-2023, among many, many others. So she's published in peer-reviewed journals, several journals, including JCO, Red Journal, Clinical Oncology, among others. So thank you very much for speaking to us today, Melinda. Welcome everyone again.
Thanks, Dr. Joseph, for a kind introduction. And as highlighted, my name is Dr. Melinda Mshonga, and I'm a clinical oncologist by training, practicing as a radiation oncology. And my subsites really are lung cancer, brain metastasis, breast cancer, and gynecological cancers. But this talk is going to be focused on lung cancer radiation oncology only. So I won't put much emphasis on the medical oncology aspect. And I will also be cognizant of the various resource capacities we have, acknowledging that, although most countries in Africa are low middle income with strained resources, we also have some who have optimal radiation oncology departments. So it'll be good to have a comprehensive discussion such that at least it captures everybody's practicing environment. So the objectives really of this talk are to discuss briefly the demographics of lung cancer, then dwell into patient workup staging and with a focus on resource-constrained settings, indications for radiation therapy in lung cancer and accompanying clinical evidence, and discuss planning to delivery, feasible step-by-step, a guide for low-middle income practice, and also with anticipation that in the next decade, we could have optimum, resources. So this will include treatment decisions, dose and technique, positioning, immobilization, simulation, volume delineation, the plan evaluation, offline review, side effects monitoring, and follow-up. I also added a few slices on lung cancer brain metastasis, noting that, brain metastasis are a common occurrence in patients with lung cancer, about 40% or so. So just briefly on the demographics of lung cancer, 2.5 million new cases and over 1.8 million deaths worldwide based on the Global Care 2020 data. And the greatest incidence is really in North America, Eastern Asia, and Northern Europe. But we also acknowledge that there could be underreporting in Africa due to even misdiagnosis as well, noting the prevalence of tuberculosis and also the additional limitation of limited research, data collection. So there could be an element of underdiagnosis. So we don't really see, presumably we don't see a lot of lung cancer cases. So lung cancer broadly can be divided into non-small cell lung cancer and small cell lung cancer, of which the most common is non-small cell lung cancer. And this tends to occur in 85 to 90% of patients, and small cell 10 to 15% of patients. So when it comes to the non-small cell lung cancers, this typically occur in the periphery, but we still do see central lesions. May look like a pneumonia on chest X-ray, more common in women. And when we compare with small cell lung cancer, highly associated with cigarette smoking, rapidly growing in many sites, and is the most aggressive subtype. But you realize that this presentation, we have a high focus on the non-small cell lung cancer, which has multiple indications for radiotherapy. So when we look at the pathology of non-small cell lung cancer, three main subtypes: adenocarcinoma, squamous cell carcinoma, and large cell, though we do have on occasion other subtypes which may include mucinous. And Molecular testing has become a big component in the management of lung cancer if funds permit, and they tend to have a role mostly in the metastatic setting, but it's also important that most of these targeted mutations are mutually exclusive. So that challenges us, like especially when you're practicing in low middle income countries to say, okay, what are the phenotypic features for patients who may have these targeted mutations so that you can streamline who may or may not benefit from this additional testing, noting that most patients will pay out of pocket. For example, EGFR positive, mutations tend to occur in women, non-smokers, and mostly Asian population, but we really don't have data in the African context. But I'm glad we have so many colleagues. We're working on genetics, and I'm hoping in the next decade we have more data to guide in terms of which patients we may need to focus on when we consider such molecular testing. So staging is crucial in oncology overall to guide treatment plan, and wake up in lung cancer is pretty much determined by the size of primary mass at presentation and symptoms at presentation. So these two images are just showing us like the different sizes, the T component and nodal distribution of patients who may have early stage disease or local advanced lung cancer, but I'll refer you to NCCN guidelines with a nice staging table just to get the more information on the different subgroups of each stage. But overall, when you're looking at early stage lung cancer, these are usually screen detected for patients who may be fortunate enough to be under a screening program or patients who are under follow-up with small nodule interval growth clinics. There are some clinics that do focus on this. And normally when you start to see a suspicious lesion, the next step is a diagnostic CT. And just based on the characterization from a radiologist, if there is a high suspicion of lung cancer, whereby if there's a low suspicion, routine 3 months, 6 month CT scan to see how that change is going to occur. But if you're highly suspicious, pathology is the next step, and most of the time this is CT guided. And these are just pictures to show, a patient who had a suspicious nodule went on to have a PET. A PET is reasonable if it's available. And the other lower slide is just showing a CT-guided biopsy taking place. But at this point in time, really, with such an early stage, definitive management can be discussed at this point, which can be surgery. I won't dwell much into that, or SBRT for patients who may benefit from it. For patients with advanced stage, these patients tend to present with persistent respiratory symptoms. So the first step really is a chest X-ray, common sense. Rule out other differentials. History is crucial, especially in low middle income countries. You want to rule out a pneumonia, you want to rule out TB. Pneumonia typically a few days, associated fever, tends to get better, after a couple of days. TB, what's the HIV status? Is there other stigmata? So that really assists in terms of, okay, should I go to the next step or not? But it's not unusual that at first presentation, you can try a patient on antibiotics, but it's crucial to advise patients to come for review for further follow-up if no clinical improvement. Because you don't want to go on to somebody who has a pneumonia, you order a CT scan, it's expensive, give antibiotics, they resolve, but you leave them in not in a great financial space. So it's not unusual to try a week, 10 days antibiotics, review your patients, and then further wake up if indicated. Typical situation for this patient had a chest X-ray, antibiotics for 10 days, no resolution, proceeded to have a CT chest, and you can see this enhancing nodule. Looks like my slides are not advancing, sorry. So this patient then had an enhancing nodule right upper lobe with associated 4R lymph nodes. So the next step really is to move on to the staging workup for advanced lung cancer. Medicinal staging, crucial, IBIS guided, standard protocol. Stations evaluated, 4R, 4L, 10R, 10L, 11R, 11L, station 7. MRI brain, if it's within the financial capability of a patient. PET scan, if available. Pulmonary function test, also useful. But in limited resources, a CT, chest, abdomen, pelvis, and a bone scan could be ideal with an associated CT brain with contrast, as we know that lung cancer does have a propensity for brain metastasis. If that cannot be attained, even an ultrasound scan, abdomen, pelvis, emphasis on adrenals and liver, skeletal survey, and you can start your management based on, with the benefit of doubt, based on these, investigations. We do that quite a lot, and some people actually do well. Standard blood work to guide systemic therapies as well as baseline. And when we look now at the indications of radiotherapy in non-small cell lung cancer, early stage SBRT hypofractionation radiotherapy are typical options that patients may have after discussing the role of surgery, which I won't elaborate on. And for advanced stage, multidisciplinary tumor board is crucial. The first step is to determine if this is resectable. And if it's resectable, surgery upfront is an option. In patients who may need downstaging to attain resectability, neoadjuvant chemoradiation had a role, still has a role, but we have evolving data where neoadjuvant chemotherapy, immune therapy may be more superior. But when we look at the cost of immune therapy, not many people will be able to afford that. So neoadjuvant chemoradiation still has a role, and particularly for superior sulcus tumors as well. For patients who are not resectable and who are unlikely able to achieve resectability even with neoadjuvant treatment, definitive chemoradiation is an option as well. And for patients who may have been deemed resectable but do have residual disease, gross residual, positive margins, and multi-station nodal involvement, as the data here is still unclear, radiation has a role as well. So in advanced stage, three main settings: definitive chemoradiation, neoadjuvant chemoradiation, and adjuvant radiotherapy. So what are those principles of radiation therapy, non-small cell lung cancer, once that decision has been made to say, okay, this patient would benefit from radiation therapy? So from a radiation oncology perspective, the steps are pretty much similar. Simulation, and that simulation we include motion management, target volume delineation technique, dose prescription, image verification, organs at risk. I will elaborate on each as I advance, in this presentation. So for simulation and motion management, including immobilization, standard would be 4D CT for those centers that do have that can be able to attain this. So in essence, if 4D is capturing all phases of respiratory cycle from 0% to 90%, including an MIP a CT scan as well. Second option is active breathing coordinator. This is really not common. And third option, which is probably available in most centers, is a standard helical CT scan. Accessories that are needed for lung cancer, immobilization include bellows for patients who will go ahead and have a 4D CT, abdominal compression system with a support frame, plate fixed with screw, in-house made at times. This may be an option in the cases of SBRT, including body fix and vacuum bag as well. Other immobilization devices that are useful for lung cancer immobilization: wing board, neck rest, and SBRT board. So this is just a picture of the different immobilization devices that we may encounter in lung cancer radiotherapy: vacuum bag, wing board, and bellows, which is usually useful when you're doing 4D CT. So a 4D CT scan is highlighted earlier. You're capturing all phases of respiratory motion. So I just put a couple of pictures to be able to illustrate this. So when we look at these CT images in the coronal, CT scans, you realize that the first one is 0%. So I've just put the contour for the 50% phase, which is the exhale phase. So some use 50, 60, just depending on the motion. So the first one here, this is a 0% inhale coronal CT. So you can tell that your GTV is shy inferiorly. But when you go on the 50, it's nicely delineated on your 50%, and your MIP essentially captures, everything. So what then we tend to do is you select your inhale, your exhale, and your MIP, then you combine those to form your ITV, of which the last one here is your average, which is the which is the IGTV encompassing the 050 in MIP, such that it's capturing all the phases of respiration. So this was a locally advanced lung cancer, hence we are seeing CTV, additional margin, 5 millimeters, but it really depends, like in terms of institutional protocols. And I didn't add the contour for the PTV, which can be 7 to 10 millimeters. This depends on, oh, sorry, PTV depends on institutional protocols as well. And when we look at how we would approach contouring for helical scan, so just to take you back to the 4D CT, we do map on the 0%, the 50%, the MIP, from the Boolean those to have your ITV, which then captures all GTV as per respiration motion for that specific patient. For your helical CT scan, because you do not have all the phases, a good trick that I learned from one of my mentors when I was doing my fellowship is when you look, if you go to the mid-plane coronal slice, when you look right at the diaphragm, if you can appreciate those little graduations where my cursor is, I try to put an arrow here, you can measure this distance. So that can be a surrogate of the amount of, motion that you have for that patient. If it's 1.5, then that means this was a patient who was getting palliative radiotherapy. Therefore, we then encompass this motion here is we extend the SOOP and INF diameter because the radial really doesn't change. So your radial margin can be 7 to 1 centimeter, but your SOOP INF can be anything 1.5 to 2 centimeters guided by the motion. And you find the motion is greatest for your lower lobe, cancers. So it's very important to just get this surrogate marker for how much that motion is so that you're able to capture um, your GTV and your setup and your internal margin your internal margin correctly. So this is one trick that we tend to use for when you're having a helical scan, particularly for palliative cases, but it's something that can be adopted for advanced cases as well if we do not have a 4D CT to assist in capturing GTV in all respiratory motions. So there's another typical 4D for SBRT. For SBRT, we don't typically put a CTV, so ITV, which is a Boolean of your 0, 50, and MIP, and we don't add a margin to ITV, then we just go straight to our PTV. Organs at risk. So the organs at risk for lung cancer really depend on the site of the primary and the indications of your radiotherapy. So for SBRT, for example, if you have an apical tumor and you're treating with SBRT, brachial plexus is going to be crucial to be included in your OARs. But if it's going to be conventional, and you know that when you look at the constraints for brachial plexus and the dose prescription in conventional treatment, you may not really have to worry that much. So that is crucial to know the indications and the location of the tumor itself. Lower lobe cancers, you may end up contouring the stomach as well, right lower lobe, your liver, and for SBRT, you would then include your bronchial tree as well. So important to know primary, where the primary is located and what your indications are to guide your organs at risk. So I then put a table just to kind of list all the organs at risk that are within the thorax in general. So planning techniques, this is also guided by intention to treat and resources as well. So you find with optimum resources, curative intent, IMRT, VMAT is the most common, palliative, 2D and 3D, but we can still use 3D for, for curative intent treatments as well. And those prescriptions, I put a table which has a number of options here, but you find the most common in the definitive setting, 1630, 66 and 33. We really don't have that much data for dose escalation lung cancer, but some people still go to 70 to 35 based on some retrospective trials. But 1630 is the most common for patients who will be getting chemoradiation. There are some patients who may not be chemotherapy candidates, but still have local advanced disease. 55 in 20 is an option, and 60 in 1615 as well. There are also a couple of dose prescriptions that I put in there that are used for SBRT, guided by location. For example, peripheral tumors, 48 and 4. And if you're treating in the metastatic setting for colorectal, knowing that they need a higher BED, 16.5. So all this really would depend back on indications, technique, and indications and technique in general. I put a couple of palliative options, like in terms of a prescription, 20 and 5, 30 and 10, 18 and 3, and 6 and 1. So these are fractionations we can consider, for example, 601 for patients who may not have a prognosis, like in terms of survival within 3 months, but present with hemoptysis. Single fraction is reasonable. 18 and 3 also reasonable for patients who may not have life expectancy more than 6 months, where you're not really where the risk or the likelihood of needing re-radiation is low. 25, this is one fractionation that is quite common, and we know we have data that is really supported hypofractionation in the setting of palliative radiotherapy when compared to 1310. And this really frees up our radiotherapy institutions, particularly high volume centers. So it's a good consideration to consider 25 for most of the palliative cases as well in our settings. So just looking into the different techniques of radiotherapy. So when we look at VIMA technique, most of the teachings in terms of techniques and how this is delivered, dosimetry, physics-led, just depending on how the radiotherapy institution is designed. In most high middle income countries, dosimetry take the lead on planning in general. So usually they're typically 2 arcs and 10 MV photons of triple F, near equal weighting most of the time. However, this is optimized with inverse planning. So ultimately, it's what you get at the end of each optimization. After planning is done and the you get a prompt to review your plan as a radiation oncologist. What are those things that we're looking for? So we have our RCU guidelines that we work with in terms of what you're trying to achieve. So this is a typical DVH. I think everybody's familiar with that. And you want your target volumes to have this nice, curve here for good dose coverage. And you always want your organs at risk to the far right of my screen here. And I have put in tables that give you the different dose metrics that you're trying to achieve from a VMAT perspective before you even approve a plan to say, okay, this one is good to go. I've also added a slide that focuses on clinical goals for SBRT in terms of what you're trying to achieve. For example, here you want for a patient who is prescribed 48 and 4, you want your 90, at least 99% of the volume to get 45.6. So this goes on to expectations as well from an OAR constraints perspective. How then do you verify treatment when the patient ultimately starts treatment? Portal film. This is probably the most common, like in terms of practice setup, where we use our portal images to make sure that we are treating what we are supposed to treat. And for centers which are at an advantage from a resource perspective, a condom CT is also is the standard, whereby you do have your 3D view scrolling and seeing if everything is matching. And it's usually you start with your bone match, soft tissue match, And there are usually parameters that are provided by each physics department to say, okay, these are our guidelines in terms of what is acceptable for our institution. So what are the side effects of patients? What do we look for patients who are coming in for treatment? So side effects really depend on intention to treat and dose prescription. So you find for patients who are coming in for SBRT, four fractions, peripheral tumor, we don't really see much except fatigue. Some may do report some fatigue. But for patients who do come in for definitive chemoradiation or even neoadjuvant, where this is a 5 to almost 8 weeks treatment, just depending on your intention to treat, patients tend to forget esophagitis, and this can be really one of those significant side effects. Tends to occur week 3 onwards. I probably see it from week 4, 5, 6 mostly. And most institutions will have an in-house mouthwash. So I also anticipate that this is one thing you can discuss like with your hospitals, what could be available. And it could be a combination of lidocaine and antacid and antifungal in different proportions to just assist patients to have a better patient experience. Tracheitis, which presents as this persistent cough, which starts, mid treatment to the last few weeks of treatment. Different cough remedies may work just based on, depending on availability. And I also find codeine works as well. It's something that one can consider. Nutrition is very important for patients who are receiving lung cancer treatment, as the esophagitis can be quite debilitating, such that patients have reduced intake. So discussing, making sure that patients are weighed every week, checking, in terms of if they're losing weight, discussing nutritional supplementation, and some dietary modifications, discussions to just ease this esophagitis. So I usually discuss with patients to eat mostly mashed foods, soups, lots of fluids, to at least maintain hydration and some form of nutrition, hoping that when they finish their treatment, they can then during that recovery phase, they may be able to increase, their intake. And if you are able to have, if you have dietitians, like at your hospital, a dietitian referral is also important upfront. Long-term side effects, radiation pneumonitis is significant in lung cancer treatment, up to 35% in literature, especially for patients who are on definitive chemoradiation. Presents 6 weeks to 6 months, that's the peak, but we can still see it late, especially if patients would then present with more serious pulmonary fibrosis. So usually it presents with a dry cough, shortness of breath, and low-grade fever, but not all patients will have these, symptoms. So if you find a patient presenting with a dry cough, persistent shortness of breath, getting worse more than 2 weeks, 3 weeks, the ideal would be a CT scan. You can actually see the distribution and how it looks like. So I didn't add a slide, but I think it was going to be important. But if you cannot get a CT scan, chest X-ray may be good enough, but you may not be able to see much. A trial of steroids is something that you can consider. Prednisone, usually 1 milligram per kg for 2 weeks. If patient starts to get better, you can then start to taper them accordingly. So you find this treatment can be even up to 8 weeks or so. Esophageal tracheal fistulas, this is possible post lung cancer treatment. So if a patient starts to present with a cough, especially after feeding, I think it's one of those that we may need to prompt a wake-up tool out this, and this wake-up could include bronchoscopy, endoscopy, to be able to assist as part of the wake-up. So you can send them to general surgery, thoracic surgery, interventional radiology for the different types of wake-up that you can do, just guided by resources as well. Esophageal stricture presents with patients with dysphagia. So if somebody presents with dysphagia a couple of months after treatment, year or two after treatment, endoscopy may be warranted. And if a diagnosis of a stricture is made, dilatation is one possible intervention, stenting. So it's important to discuss all these expectations with your patients, such that if they're not going to be seeing you, like in terms of, we know the high rate of loss to follow up, they may, if they see any of these symptoms, they come back to hospital for an assessment and get the proper guidance. Rib fractures are usually common post-SBRT, presents with a pain or even persistent pain after a minor fall. Chest X-ray is something that you can do up front, just rule out a fracture. CT scan if resources permit, and normally this is conservative management with analgesia and some counsel in terms of how to um, analgesia and some counsel in terms of how to assist in not interfering with the healing, which could be a bit on the slow side. Discomfort over previously treated area is one of those things that may occur. Patients may present with this increased sensation of a treatment field. Most of the time, you may not be able to do much, just counseling and reassurance. Brachioplexopathy, possible for patients who have superior sulcus tumors or upper lobe tumors as well. So this may present with upper lip pain, and that distribution will really depend on your tumor location as well, but within the brachial plexus nerve distribution. So follow-up in general is up to 5 years, and this is as per NCCN guidelines. I didn't dwell much on that, but initially you're doing, CT scans, and even just symptom evaluation and a chest X-ray is good enough. And that follow up the first 2 years could be every 3 to 6 months, just depending on if the patients where the patients stay and what is feasible in your situation. And we could even take advantage of virtual clinics whereby just as follow-ups, speak to the phone, screen symptoms. If anything is concerning, you can really strongly guide patients to come back to hospital for further, wake up. So just zoning into management, this I'll be quick because I think I probably elaborated on that as we were talking about indications. T1 to T2, surgery, standard of care, if not suitable, RT, SBRT or hypofractionation. And these days, a number of patients, even though they are, they are surgical candidates, they opt for SBRT or hypofractionate SBRT because of equivalent outcomes from a disease control perspective. But it's important to highlight that in as much as the disease control is similar to surgery, patients who have SBRT have probably an over 5% risk of presenting with regional recurrence when compared to patients who've had surgery. So it's important to elaborate that on patients so that they make an informed treatment decision. Principles of SBRT, I think I focused on that on earlier slides. 4DCT, your 050 MIP, Bullen those, PTV 5 millimeters and different fractionations. I think we went through that. Technique is usually VMAT or IMRT. So this is just a slide which is telling us the different clinical evidence that support SBRT and how that approach may look like just depending on the location of tumors for patients who are eligible for SBRT. So it's always important to note if you're dealing with an ultracentral, central, or peripheral tumors, as fractionation will be guided by location to reduce the risk of toxicities which may be fatal. For T1 to T4N1 disease is elaborated before MCCs, discuss surgery. Is it feasible? If patients are resectable upfront, if probably resectable, neoadjuvant treatments can be considered. Chemo-IO is the standard based on Checkmate 816, but chemoradiation can also be something strongly considered, especially when we do not have immune therapy or systemic therapy alone for some situations where radiotherapy may not be available. And N2, N3, most of these patients are not resectable, so chemoradiation, definitive, it's usually the standard of care. So one of the practice-changing trials for patients with stage 3 local advanced is the Pacific trial, of which it really showed improved outcomes when compared to chemoradiation alone for patients who went on to receive durvalumab. So they were quite impressive 5-year overall survival rates, which were up to 42.9% compared to 33% for patients who did not have durvalumab. So only if it is available, but we with improved resources in future, it's important to have this at the back of our minds that for patients who would have received chemoradiation, durvalumab, adjuvant durvalumab has really improved survival outcomes in patients with local advanced lung cancer. And for neoadjuvant chemoradiation, as highlighted earlier, standard of care currently is chemo IO, but we do have our traditional trials that have really looked at neoadjuvant chemo RT. And these are some of the trials we can refer to when we are discussing with our patients. So still an option for patients who may not have access to uh, chemo IO and in the neoadjuvant setting. So just to go through maybe a bit of a discussion. I don't think I can be, I'm hoping the organizers, Dr. Joseph, can be able to assist me here if anybody is able to, participate. What challenges can we anticipate on planning just based on the discussions we've had for this patient here?
All right, so thank you very much, Dr. Mushonga. I don't see any questions in the chat yet. So if anyone wants to ask a question, contribute, please feel welcome to leave a message in the chat, or you can even raise your hand. But I think that the one thing that people, you've covered the indications for radiotherapy adequately. So these are the questions that we had received from previous sessions. When is radiotherapy indicated? When exactly do I need to think about radiotherapy? The second thing is that when radiotherapy is indicated, how do I plan? Which you've also covered, adequately. What are the things I need to think about in terms of target delineation? What are things we need to think about in terms of positioning and organ at risk protection? And then also talking about side effects, management of side effects. I think one of the important things that you've talked about is toxicity, in terms of the long-term toxicity to the surrounding structures and all of that. Can you talk a little bit about the heart in the thorax?
That's a good question. Yeah, I did not elaborate on that. I don't know why I didn't. So yes, the heart cardiac, it's within the thorax. So we also do have constraints for it. I would just go back to my slide, but it really depends, like in terms of also, tumor location. So if you are close to your CAD, there is we pay particular particular attention to that as well. And I know in terms of resources, it may be difficult to even be able to locate our CAD, which really is one of those substructures of the heart that may really, predict in terms of the risk of any cardiac toxicities. So in summary, yes, we may have cardiac toxicities, but these are usually in the long term. Patients may present with cardiac failure, and they may present and cardiac failure, bilateral leg swelling, shortness of breath, and pleural effusions. So if patients present with that, they may mimic radiation pneumonitis. The only difference is with cardiac toxicities, they will have bilateral pedal edema. So cardiac wake up will be warranted, doing your echo and every other cardiac associated wake up. And normally then they may need to be seen by physicians or cardiologists to address that. So yes, it's a potential toxicity for radiation, lung
Yeah, so
radiation oncology, but less than 5% really, especially with modern technology.
So what I wanted to say, so thank you for answering that, but then elaborating more on the heart, what are the things that you need to think about or do ahead of treatment? So, for example, heart disease is a very common comorbidity in Africa. Many of your patients will have hypertension. Do you need to
Correct.
echo? Do you need to do an echo before treatment? Do you need to keep them on echoes after treatment? If they're hypertensive and on antihypertensive medication, how are you supposed to manage that in the context of treating this?
So it's not standard that every patient goes for an echo from a radiation perspective as a baseline. But when we take a comprehensive history and you're looking at the risk factors, if you have a patient we have hypertension, which is uncontrolled, and they have a higher risk of having, cardiac toxicity, it's reasonable to optimize and get those baseline, baseline wake up, which may include an echo, but this is now patient specific. But we would not routinely send a patient for an echo because they're going to get, radiotherapy for lung cancer.
Okay, so I have a question that's been sent to me directly. So could you elaborate a little bit more on the dosing and the dosing schedules? And then, so in a center where there's no 4DCT, how is it possible to do SBRT, and how exactly, do you go about that?
That's a very good question. So I'm just going to take the dose prescriptions here. I think it will be difficult to be able to start an SBRT program without a 4D. Why? If I go into, let me just go to this slide, which is showing the different motion phases, the different respiratory cycle phases. I would anticipate for a tumor, which is probably 8 millimeters. This is small. And if your coronal does not show that marked motion and its upper lobe, and the patient has no other plan, I think a helical CT scan may make sense, but you may need to put a CTV margin because traditionally we do not put a CTV margin when we are treating with SBRT because you would have had your IGTV, which is a combination of your 050 and MIP. So this now becomes more of personalized and trying to be innovative to say, okay, if it's an 8 millimeter biopsy confirmed, I have this patient cannot have surgery. This is an 8 millimeter. I have a helical scan, right upper lobe. When I look at my coronal, there isn't any motion. I think it's reasonable to consider, especially if your organs at risk is going to be like, in the periphery, you don't have any organs at risk. You can consider, but I'll probably put a CTV and a PTV together and discuss with the patient because ultimately your volume of PTV also matters. But if it's going to be somebody who comes with a 3 centimeter mass, that's on the bigger side, and it's in the lower lobe. And when I look at the motion, it's concerning. The first one important principle of radiation is treat cancer and treat it safely. You don't want to be heroic. So you don't want to be giving SBRT, 3 centimeter lesion, lower lobe, so much motion. You know you need to expand to cater for your, internal margin. So it's very, very personalized approach, but the standard would be a 4DCT if you're to start an SBRT program. But knowing resource limitations, at times you have to be innovative.
Thank you for that. So, because I was just going to say that for me, I've never done SBRT for lungs. It's always been conventional. I don't have 4DCT. So I've treated with conventional doses. And in the past, we didn't even have respiratory gating or motion management. But now, I mean, with motion management, you can still treat very reasonably and successfully with conventional radiotherapy and conventional fractionations. So we didn't answer the question about dosing, yes. So can we go into the dosing a little bit more and then perhaps maybe talk about just conventional, treatment for.
The conventional treatment is going to be like the main indications will be neoadjuvant, chemoradiation, definitive chemoradiation, or radical radiotherapy alone for patients who may not be chemotherapy candidates, and a small cohort of patients who need adjuvant radiotherapy post-surgery and have gross residual disease or positive margins. So in the definitive setting, the standard is 60 to 30. That's where we have level 1 evidence. But we do have situations like some trials that have dose escalated 6633, 1735 in some cases. So you find when you look at NCCN, it'll give you a range, 60 to 70 in 30 to 35 fractions. So this is the definitive dose fractionation for patients who will receive chemotherapy. For patients who are not chemotherapy candidates, locally advanced, 55 gray in 20 fractions is an option, or even 60 in 15. But 16-15, there was a trial that looked at patients who got 16-15 versus 16-30 with chemo radiotherapy, and the rate of grade 3 esophagitis was quite high. So this may take a toll for patients, especially the elderly who are not really chemotherapy candidates. So 16-15, 55 in 20 are some of the radical hypofractionation doses that we use for patients with local advanced who are not chemotherapy candidates, hypofractionation. Then for patients post-surgery, this could be 54 in 27 fractions, and in the neoadjuvant setting, 45 in 25 fractions, because you also want to not complicate the surgical bed for the surgeons. That's why you find this is a lower dose at 45 in 25 for patients who are getting neoadjuvant chemoradiation. So neoadjuvant, lower doses, 45 in 25. Um, Adjuvant cases, 54 in 27. Definitive radiotherapy with no chemotherapy, 16-15, 55 in 20. And definitive chemoradiation, 60 to 70 gray in 30 to 35 fractions.
So just taking some questions there. Can you give 60? Okay, yes, I see your question, Dr. Bashir. So just take this one quickly. Can you give 60 gray in 15 with conventional radiotherapy without SBRT?
Oh, yes. So we can give 60 in 15. Absolutely. We can give 16, 15. This will be hypofractionation. So we tend to give that 60 in 15 in patients who have a locally advanced lung cancer, but even some central tumors that are, abating your large vessels, your trachea and esophagus, whereby you cannot give SBRT doses such as your 48 and 4 and 16-5. So some of the fractionations we use in a hypofractionation where you want to really dose escalate, 16-15, 16-8 in some cases.
Okay. So next question, how would you approach in terms of giving radiotherapy to a left lung cancer patient with an ejection fraction less than 40%?
That's a good question. So there are going to be a lot of things here to consider. And we do come across some of these patients because when you look at, comorbidities, most lung cancer patients will have comorbidities. You want that patient to be optimized. Let them be seen by internal medicine. Because at the end of the day, it's a matter of what is a competing comorbidity. Are they going to die from the lung cancer or the heart cancer? The heart cancer can be managed, but they may die from lung cancer. So optimization is important. Let them go see a physician, internal medicine. They are optimized, and make sure that you are strict on your constraints. Because at times, planning can be so hard that at times you may not meet your primary goal and you tend to rely on the secondary goal. But these are the patients where you really have to meet your primary goal, and you may end up having, like, in terms of when you're doing like your planning, you may then end up optimizing your dose to just the GTV, particularly if your PTV is going to be encroaching towards some critical substructures of the heart. So these are things, some strategies that you can do at planning level. But the most important thing is to optimize, get them have their heart failure under control. Then you can start your treatment. I've had a patient, we had like an ejection fraction in the 20s, optimized, doing well. So it's not a contraindication to proceed with treatment. The issue is optimization, close follow-up with cardiology, even after treatment as well.
Thank you so much. So next question, I think you talked
I
about
have a
this.
number of slides. Okay, sure.
Oh, you said I was like, well, I'm getting questions now. I guess people think we're at the end. So let me just take the next two questions and then we'll go on. So one question is, can you achieve motion management without respiratory gating? And then let me see the next one. What QA considerations are essential for hyperfractionation, e.g. 16-15 using 3D-CRT? So two questions. I don't know if you want to take them now or wait till later.
Maybe
So,
I have
okay,
a couple of cases as well as we
okay,
go forth. So let me take them later, those last two. after I just go through some cases to see if we don't get any clarity overall. But it all comes back to, briefly, I think we did discuss in terms of how you approach motion management when you have like a 3D CT, which is a helical scan. So you're just going to your coronal, you're measuring this changes graduations to get you know, an idea of how much motion you have. You include this in your margin expansion. So this is one strategy you use if you do not have a 4D CT scan. This is something you can have from your 3D helical scan. So I had asked this question like in terms of what what challenges can we anticipate on planning for this patient was presenting with a locally advanced lung cancer multi-station nodal involvement who is planned for chemoradiation in codes. Anybody willing to just give a brief attempt?
You can put your answers in the chat. What challenges can we anticipate on planning this patient?
The
I
patient
think,
who has supraclavicular
yeah.
node
So, I mean,
and a lower lobe mass.
trying to get your OAR doses, toxicity, positioning.
Toxicity.
Yeah.
Toxicity, exactly. This is one of those cases where meeting the lung constraints can be an issue. And radiation pneumonitis can be a serious side effect of lung radiation. So when you are not sure, like in terms of if you're going to meet constraints, at times we have proceeded to plan, but if you fail to meet constraints, it's not unreasonable to not proceed with chemoradiation, give this patient neoadjuvant chemotherapy, then bring them back to planning after 2, 3 cycles to then reattempt planning. So meeting constraints due to SOAP inferior extent of disease and what treatment options can then be considered, the chemotherapy that I mentioned, just to kind of, I'm just looking at the time. So this is a case of a patient who had a superior sulcus tumor and is planned for surgery. Just based on the discussions we've had, what is the dose prescription which is ideal for this clinical scenario? I just want to make sure that everybody's following. Any attempts?
I don't want to answer. Please put your answers in the chat. So we're looking at neoadjuvant treatment. You don't want to give a dose that's too high so that the surgeons don't have difficulty at surgery. So, okay, perhaps you should remind the audience.
That's okay. I'll go back to our dose different dose options, which we discussed just now. 45 and 25. This is one dose that we use in the neoadjuvant setting in general. Okay.
Yes, and Irene has put the correct answer. Irene put the correct answer in the chat, 45 and 25, because you want to limit that dose and not go too high.
Thanks, Irene. So I did give you, like in terms of the planning, some images just to show a bit on the planning techniques. Would anyone want to attempt to tell us what planning technique was used for this patient and why? Is it 3D? Is it IMRT? Is it VMAT? Any attempts, Dr. Joseph?
Well, I mean, to me, it looks like an IMRT plan that could be
Exactly.
set up. Yeah.
Because you can tell their multiple fields. You can tell from your
Yeah.
isodose curves that in terms of how our dose is going to be distributed and all. Why I put up some of these cases and some of these pictures is as we advocate with our administrators in terms of having some of these techniques available, it's important to know the advantages and disadvantages of the different techniques that we have. In as much as we understand most people are using 3D, there's good sparing of your OAR such that it may be worthwhile to advocate for further advances just guided by when we speak to administrators guided by the data we have. So this is one of those trials that's looking at the clinical evidence for induction chemoradiation. These patients get 45 and 25 gray. That's the example that I put in that other case that we just did, whereby this patient went on to have surgery and had neoadjuvant chemoradiation with 45 gray in 25 fractions. So I have another case of a patient, 39-year-old, EGFR negative, non-small cell lung cancer, positive margins after upfront surgery. What is the recommended adjuvant treatment for this patient, including fractionation that one may consider? Any attempts based on our dose table that I shared earlier?
So I think maybe after the session, Dr. Mushonga, if you don't mind, you can do like a dose table, neoadjuvant, concurrent, adjuvant, and then we can share that with attendees just so that everyone is very
Yeah,
comfortable having the
confident.
reference. Yes.
Yeah, no, that's fine. So 45 to 50.4 is one of those doses that we would work with in this situation here. And we have a couple of trials that look at the role of post operative radiation therapy, and the major ones are lung art and the Part C trial that has shown, limited benefit really, but suggests some benefit for patients who have gross disease and multi-station nodal disease. So I won't dwell much into these trials, but these patients got 54 grade, 1.8 grade per fraction, which is one of the fractionations that we use in the adjuvant setting. So this is just some, a couple of slides elaborating on lung art trial findings as well. And the Part C trial as well is also post-operative radiotherapy trials, which look at the role of radiation in this setting, and their dose fractionation was 50 in 25. So you find that range is anything between 45 to like 54 grade, 1.8 to 2 grade fraction in the adjuvant setting. So metastatic disease, patients with lung cancer metastasis should be considered for best systemic therapy, and that's the mainstay of treatment. But palliative radiotherapy has a role in to improve symptoms overall. So this is one of those cases. I put two cases here of two patients who received palliative radiotherapy. This one is a 2D simple APP field, and this one is by VIMA technique. So one of the considerations that one may have in terms of choosing technique is if it's a patient who has, metastatic disease, large perihilar mass, compromising breathing, hemoptysis, and they do have perhaps a mutation whereby they have access to targeted treatments and therefore their survival can be even up to 2 years. VMAT may be a reasonable choice if available, because in this way, you can consider re-radiation in that case. And we have a couple of patients we do re-radiate 3, 4 years after the initial radiation of 20 and 5. And some of the fractionations we use is 20 and 8, and we rarely see any toxicities, and patients actually do well after that. So if you are anticipating re-radiation and you have access to VMAT, because it takes time as well to plan, is something that you can consider. But if you don't, APPA is still reasonable. But the trade-off now is we have much, larger lung, high dose volume to lung. And when you need to re-radiate, you may face some challenges. So it's one of those things to consider. But either approach is fine, just guided by the clinical scenario, what systemic therapies they have, and what resources one may have. So this is just elaborating on advantages and disadvantages of proceeding with either VMAT or 2D in a palliative setting, particularly if re-radiation is a consideration. So for patients with limited metastasis, approaches can also be different. I won't dwell much on that. But this is one patient we had metastatic disease, EGFR positive. I thought this was important because radiotherapy may have a role later on in patients who may present in such situations. Multiple lung nodules, had osimertinib, literally resolved, and this was the only lesion that was left, like after about a year or so, if I recall. Then at the 2-year mark, there was regrowth of this one here. So we then proceeded to treat this one with SBRT, and the patient was maintained on their TKI. So even though this was metastatic at baseline with multiple lung metastasis, there is a role for radiotherapy, just a case-by-case basis, guided by the clinical scenario in patients who are well with limited oligoprogression. So 2 trials that focus on oligometastasis, KERB trial, Sinus trial. I won't dwell much into that. I think you have access to the slides, so you can have a look, just to guide treatment decision and some of the data we have and currently. Then proceeding to discuss briefly lung cancer and brain metastasis. We know up to 40% of people with lung cancer develop brain metastasis at some point, and radiotherapy technique really depends on the number, size, molecular profile, and whether it's symptomatic or asymptomatic presentation. So I'll probably do this approach this as a case-based discussion where we have an 81-year-old patient presented October 2023, de novo metastatic EGFR positive non-small cell lung cancer, 3 brain metastases, of which the largest was 2 centimeters. So brain treatments have evolved a lot, where if you have access to, VMAT, SBRT, we now approach this with what we call FSRT, where we are just treating the metastatic lesions only. And this patient was treated O3, started on osimertinib after treatment, and has really been doing well. Came in for review June 2025 and remains well controlled, but had a new 2 mm lesion, which we treated with FSRT just this past week. So this is something that can also be considered as we look to the future when things, resources permitting. Case 2, 69-year-old non-small cell lung cancer, ALK positive. As I mentioned in the earlier slides, that molecular profiling has a role, particularly in the metastatic setting. So for this patient here, we started upfront on a TKI because they were symptomatic, 6 intracranial lesions, of which at time of assessment after 8 weeks, 3 of them had resolved, and we then treated the remaining ones with FSRT, and they remain well controlled to date, and it's now about 2 years as well. So it's not unusual to find multiple brain metastases or even situations where we may not have, FSRT capability. Whole brain radiotherapy still has a role in local control. So this is the typical fields that we use for whole brain radiotherapy in patients who have brain metastasis. So it's a standard POP, 6 MV, and I think we can all, most radiotherapy institutions will be able to, deliver whole brain radiotherapy, using the 2D technique. Small cell lung cancer, largely divided into limited stage, whereby chemoradiation is a role, and extensive stage, systemic therapy upfront. But there's a role for consolidative thoracic radiotherapy for patients who have residual disease. And typically we treat these patients with 30 gray in 10 fractions, but we're moving towards 25 fractions as data evolves. So this is one of those trials that support the use of thoracic radiotherapy consolidated for small cell lung cancer in situations where there is residual mediastinal disease to optimize local control. Prophylactic cranial radiation is one of those big discussions in small cell lung cancer, and we know in limited stage we do have evidence supporting upfront cranial radiation, but in extensive stage, we have two major trials which literally showed different outcomes, the Slotman and the Japanese, one showing improved survival, one maybe not. So we have an ongoing trial, Maverick, which we think is the tiebreaker. So for extensive stage non-small cell lung cancer, it's a discussion with the patient to say, okay, upfront cranial radiation or MRI surveillance, but noting that MRI surveillance is expensive. And for patients in low middle income countries, prophylactic cranial radiation may be reasonable in this case. So I think it will be important to just master some of those, the following principles of radiation therapy, non-small cell lung cancer management, the indications for adjuvant radiotherapy, the different dose prescriptions. I think we still need to kind of work on this as well. Oligometastatic management as things improve from a resource perspective, potential side effects management, and re-radiation, important aspects to work on. So that's the end of the presentation. I don't know if there are any other questions that we may address.
Thank you very much, Dr. Bishoga. This has been wonderful, very relatable, and very applicable. I do have questions, lots of questions. Thankfully, we have up to 20 more minutes. So hopefully we will be able to get through with them. So one thing now, since stage 3 is highly likely to have systemic disease, how much superior is SBRT to conventional chemotherapy? Overall survival or symptom-free survival?
So stage 3 disease, this is likely not positive disease. So not positive, we do not treat with SBRT, with not positive disease. I think it's very important to clarify that. Stereotactic body radiotherapy is for early stage lung cancer, not locally advanced or not positive. So that's a big difference. So the standard approach for stage 3 would be determine if this is resectable, most likely unresectable, but can you convert them to being resectable? That's when you may consider neoadjuvant approaches. What are those neoadjuvant approaches? Chemoradiation or chemo-IO, immunotherapy, if patients can afford, or chemotherapy alone if you don't have any radiation. So these are typical non-neoadjuvant approaches that you may consider in your setting, of which the standard of care, I will emphasize, will be chemo-IO, but guided by resources, chemoradiation, neoadjuvant, or even chemotherapy alone are still reasonable. This is stage 3. Re-image, and if they can be converted to resectable, proceed to surgery. If the patients have unresectable disease upfront, chemoradiation, 60 to 70 gray in 30 to 35 fractions at 2 gray per fraction for patients who are able to tolerate chemotherapy. We have a cohort of patients who may not be able to tolerate chemotherapy, be due to age, comorbidities, or even finances, but radiotherapy is available. What can you do? 55 and 20, this is not an SBRT fractionation. This is hypofractionation. Or even 60 in 15, this is not an SBRT in codes approach, it's hypofractionation. So I just need to make this clearer. But some may argue within the 60 in 15, the way you plan, you may plan in such a way, I should have included this slide, that shows a 60 in 15 planned with an SBRT approach where the high dose fall off is within like a centimeter versus the 60 in 15, which is planned in a conventional, safer fractionation, especially when there are limitations with motion management. I'm not talking about the SBRT one because this is now stage 3. So stage 3 would be a hypofractionation approach, conventional approach, which is hypofractionation. So 16, 15, 55 and 20 are options that are available for patients who will not get chemotherapy in a stage 3 setting.
Thank you. That's a very comprehensive answer. So now next one second now. Okay, so this is a chemotherapy question, and we won't spend too much time on it, but I do want us to answer the question just because it's relevant. So it says, in terms of best systemic therapy, which chemo combinations would you recommend in low resource settings where IO and targeted therapies are limited?
During my training, we used a lot of platinum-based and paclitaxel or
Pemetrexed.
or pemetrexed as well. So I haven't been up to date that much, I'll be honest. But those are the main ones that are used, and I think they're reasonable. Because when you go back to the data, like even if I go and just look at a Pacific trial, 5-year overall survival data, overall survival was what? 33% or so for chemoradiation versus 42 for chemoradiation immune therapy. So in as much as it's inferior, you still have, commendable outcomes. So we can still go to baseline all these evolving trials at some point in time. What we have right now was a standard of care at some point in time. So we can still use that. So cisplatin, platinum-based, cisplatin, carboplatin, paclitaxel, or pemetrexed for adenocarcinomas are still options, but I'll probably defer that to my other colleagues who are doing more medical oncology.
Yes, but I think you've covered it very adequately. So platinum-based chemotherapy, Taxol, pemetrexed, traditionally standard of care. So how do you achieve motion management when you don't have respiratory gating or 4DCT? Can you achieve motion management without respiratory gating?
So you are now accounting for that using your margins. That's the thing. So I will go back to this slide here.
So we have more questions, so I'll just
Yeah.
encourage you not to spend too much time on this one. Okay.
Yeah, it's an important one. It keeps coming up. So
Yeah.
this is the standard CT that we have. So you're going to account for that motion by using margins that are determined by your motion for that patient. How do you determine that margin? You measure, can everybody see my cursor here on this?
Yes, we can. We can.
Exactly. Do you see those little hazy graduations here?
Mm-hmm.
So if you measure this distance here, if it gives you 1.5 centimeters, you increase your soup inf by 1.5 to cater for that. If it's 0.5, really, if it's 2 centimeters, you increase that as well. Because ultimately you're not capturing all the phases of respiration. And most of those patients, mind you, they have comorbidities, chronic smokers. So it's one of the strategies that you can do at time of planning, if that makes sense, by catering for that motion as you increase your margins during your planning.
Mm-hmm. Thank you very much. And I think, I mean, in general, if you just do so, if you do something like get 2 scans, I remember that then you would get 2 scans, one at inspiration and one at X-ray. Ask the patient to hold their breath and scan, and then do another one, and then ultimately try to get like an ITV. I mean, that's not saying that that's a method of
Like
motion
breath hold. Yeah, we use that in breast as
like
well.
doing a
Thank you for
DIBH,
that.
exactly.
Exactly. Yeah, you can do that as well. Exactly. Yeah,
Yes,
thanks for that.
the only challenge with that in lung cancer is that, as you said, these are patients who have lung disease. So breath hold
Exactly.
is not always tenable for a patient in that condition. But I mean, if you
Exactly.
can,
And it's
and
7 weeks of treatment.
exactly, exactly. So, and then there's other things as well that you might consider that might not give you a perfect plan, but even things like abdominal compression,
Yeah, we
would
discussed
reduce
that. Yeah,
the motion of the, yeah.
yeah.
So the next question says, without PET-CT, how can you define target volumes and minimize normal tissue radiation? So you don't need a PET-CT. Yeah,
No,
let's
it's
take that.
exact. You can use your standard CT scan in summary. In summary.
Okay. So, have you tried dose escalation before to try and get curative or definitive radiotherapy? And how will you balance that with excess toxicity? That's the next question.
So I've never treated to 70 gray. I've always treated to 60. I think all the institutions that I have passed through, they have standard protocols where it's 60 in 30. And at the end of the day, it's very difficult, like in terms of if we are to replan midway in terms of if somebody is having either tumor progression or regression during treatment, because it's also not unusual to replan during lung cancer treatment due to either response or even, some changes that we see on the planning CT scan. It's very hard to say like it's 60 gray, okay, this is so large that the next 10 gray will make such a difference. I've not seen that. I don't know if other people do that, but planning upfront, I've always done up to 60 gray.
Okay, so two more questions and then we can wrap up this session. Thank you so much, everyone who stayed with us. So two questions and I'll read them both at the same time. What is the minimum QA process that you consider to be essential before attempting hypofractionated or SBRT-like regimens? That's one. So minimum QA process. The second one says, how do you compensate treatment plans when faced with interruptions or machine breakdown during a radical course? That's a good question. I mean, for a 7-week treatment course, treatment breaks, are likely to occur. So,
That is an important question. So I remember treatment breaks were an issue, like in terms of when I was practicing in Zimbabwe, and we had this nice chart that the physics team had that had a formula used to account for that treatment break. And normally, just depending on how long it is, it was a matter of additional fraction or 2 or 3 that would be needed at the end of treatment to achieve the same BED that you would have wanted at initial planning. So there is a formula that can be used to account for that treatment break. And ultimately, what you're trying to derive at the end of the day is how many additional fractions that patient needs to get to the same BED dose that you want, if assuming that the patient has gone without any interruption. That's in summary. So in terms of QA process, I always come back to the basics of radiation oncology to say we are trying to treat cancer cure cancer and do it safely. And how do we do that? We're going to delineate our target volumes and our OARs. How do we verify that? We're going to use our portal imaging and we're going to do the con-beam depending on availability. I think as a starting point before you even proceed to SBRT is we've been using conventional fractionation for local advanced cancers. Going back and doing a retrospective review in terms of how the matches have been, like in our specific departments, just in retrospect, what is our margin of error? What can we improve on? And start to do that even for palliative cases. And once we know that we are meeting the criteria of, our respective departments in terms of meeting our margins at error that are defined, then you can be comfortable to move on to SBRT, some of these escalated doses. So at minimal retrospective studies on what has been done before, then optimize in terms of improving verification, you're matching with palliative cases, conventional cases, before you then attempt some of the easier cases, such as smaller tumors, peripheral, that are away from most organs at risk, to see if you're still meeting those metrics from a verification perspective. Then you start improving, step by step from that point. But retrospective studies are always a reasonable starting point. That way, you then see what your limitations are, what you can improve on going forth.
Thank you very much, Dr. Mushonga. So I think with that, we've come to the end. I believe I've taken every question that has been sent to me. I don't see any ones that I have not answered. Thank you for a very relatable, very reasonable and feasible lung cancer radiotherapy session. So the slides will be shared, and the recording will also be available on Aortic channels later. And if you do have any questions or any concerns, please feel welcome to send an email through Aortic. We hope that very soon there's going to be a number of lung cancer networks that you can reach out to. And we're really working hard to increase the utilization of radiotherapy for lung cancer treatment in Africa. So thank you very much, everyone, for attending today. And I'd like to ask everyone to enjoy the rest of their day. Thank you. Thank you very much, Dr. Mushonga.
Thanks, Dr. Joseph, for organizing, and the rest of the IOTech team.
Yes, that was a great session.